بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين محمد وعلى آله وصحبه وسلم أجمعين. Good evening everyone, greetings to friends and colleagues. It's my pleasure today to welcome you all for monthly live online webinar arranged by Saudi Society of Pediatric Dentistry. I would like to take this opportunity to thank the President of Saudi Society of Pediatric Dentistry, Dr. Aziza Jawaher, and her scientific committee for all their efforts to keep the society member up to date and invite distinguished speakers to sharing with us their knowledge, informations, and experience. Thank you very much. Today we have two fundamental lectures with important topics by two distinguished speakers. I would like to remind all the audience if they have any question to be sent through a Q&A icon in the webinar. Our first speaker has a distinguished CV. It is an honor to present Professor Mawlood Kowash with his presentation titled Early Childhood Caries and Epidemic Oral Health Problem in GCC Countries. Professor Kowash received his dental degree from Benghazi, Libya in 1985 and has his master and doctorate degree on dental science and pediatric dentistry from University of Leeds, UK in 1993 and 1999. He became a member, a fellow of Royal College of Dentists of Canada in 1998. In 2015, became a fellow of Royal College of Physician and Surgeon of Glasgow and fellow of Royal College of Surgeon of Edinburgh in 2019. Currently, Dr. Kowash is working at Hamdan bin Mohammed College of Dental Medicine as a professor in pediatric dentistry in Dubai. He is an external examiner in pediatric dentistry at National and International Dental School. Dr. Kowash has supervised several master's projects and has several publications in international peer-reviewed dental journals. In addition, he is a regular guest speaker in national and international dental conference. He is a reviewer for several peer-reviewed journals as well. Welcome, Professor Kowash. You can share your screen and start your presentation.
Thank you very much, Dr. Jawaher, and this is, it's a good opportunity to share my, actually, I love this topic, and it my PhD in there. So first of all, I want to thank Dr. Aziza and her team. You are doing a really great job, doing this CME every month. So the topic today is my screen on today now? Is that it? Can see my slides?
Yes, Doctor.
Oh, thank you very much. So, early childhood caries and epidemic oral health problem in GCC. I just want to define that term epidemic. It's an epidemiological term, which means that a disease is widespread within a country or a region like GCC. In the country, pandemic like COVID, where the disease is actually worldwide and it's across the continents. So in this presentation, okay. So hopefully by the end of this presentation, we will define the background, what are the ECC definitions, terminology, clinical. Just quickly, I know most of the audience may be a pediatric dentist, but I'm sure there will be a general dental practitioner and a student also. So just refresh your minds about the background of ECC. And the most important, I just shed some light why we are not really managing ECC successfully. What are the misconceptions and there's no, I did not do any research on this, but this is just an assumption that why we are not managing the ECC successfully. And we will discuss briefly also the evidence-based preventive and treatment strategy and present to you the paradigm shift from drilling and filling to the seal and heal approach. And we will discuss together clinical scenario questions. So I declare that they have any conflict of interest or any financial interest in this. So what's ECC? ECC is defined as the presence of one or more decade missing or filled surface in a child who is less than 6 years. And if we see any sort of like smooth surface caries in a child who is less than 3 years, then we call it severe ECC. Now, what are the terminology? You know, there are many confusing terminologies used to be in all textbooks, and prior to the 1997, like nursing caries, nursing bottle caries, nursing bottle caries, all of them, if you see, like, they blame either the bottle or maybe the pacifiers, but all they don't have the concept of, you know, of multifactorial nature of the disease. So after that meeting where they come up with a paper, I think that was Tenenoff and O'Sullivan. So they come up with ECC, early childhood caries, and it's now generally accepted term. Now, what is the clinical picture? The clinical picture is actually pathognomonic, where the caries usually starts in the neck of the teeth, in the facial side, as demineralization. And this is very, very important, you know, from sort of like prevention point of view. So if we see that white lesion, then we can intervene, and just by doing a Durafat, and then, you know, the case can be reversed. But the problem, if it's allowed to, you know, to proceed, and it do really go to very, very expensive, extensively in a matter of maybe even 6 months or so. So because it's chronic in nature, so usually there's no pain, and you know, the children, especially in our region, they don't come for treatment only after maybe you just see a root stumps, and then the teeth unfortunately has to be taken out. And why this clinical picture? Because of the anatomy. You know, usually during suckling, either breastfeeding or bottle feeding, you know, the teeth, the lower teeth are sort of protected by the tongue, and that's why the milk accumulate around the necks of the upper teeth. So that's why it starts at that area. Now, etiology, as you know, this is a classical sort of diagram. Everybody knows about this, but really it's very, very simplified one. The more of you, if you like, maybe giving us a more correct picture is this one, is the multifactorial nature of the disease, involving everything, not only black tooth diet and, you know, saliva. So everything can be, you know, like socioeconomic status, education, behavior, and attitude. And also, we don't forget about the enamel defects, which is, and actually we have researched it by Dr. Hanoud Shahi, who published her paper in the enamel defect of the preterm or, you know, low birth babies. And also, we don't forget about the demineralization of the deciduous teeth, which is also a very good predictor of deciduous molars. And of course, we see caries in these teeth. Now, we know from the work of Paul Kais in 1960, he did great work in the lab, you know, using mice, and we know that it's transmissible disease, and actually he called it even infectious disease. But now this idea has been changed. It's transmissible disease for sure, from parent or especially mother, vertical transmission, or could be a horizontal transmission from other family member, like including nannies, you know, especially if the nanny or the maid, you know, used to nurse the infant or toddler, then she can transfer her Streptococcus mutans, especially to the child. And these are the two main microorganisms, namely the mutant streptococci and the lactobacilli. Why? Because they possess two main properties with acidogenicity. That's the ability of bacteria to produce acid, and aciduricity, where the bacteria produce acid and live happily in an acidic nature. So that's why, I mean, in theoretically speaking, any microorganisms, including yeast, in the lab can cause demineralization or fermentation, sorry, of sugars, and can cause caries. But these two microorganisms are the most important one. And I think most of you, especially pediatric dentists, are familiar with the window of infectivity, that nice paper by Cofield, where he said that, you know, there is a window which opens and closes, but the most important period is between the 19th and the 31st month of the child age. and the median of 26. So this is very, very important. And actually the transfer of bacteria occurs in this period. Treatment actually said that ECC is a biofilm mediated non-communicable disease. So it's not really classical infectious disease, but a sugar driven of a commensal. Then there is a problem. Usually the bacteria, they live together in a symbiotic balance, but in the presence of sugar, there will be this dysbiotic imbalance. And we know that normally in the normal conditions, there are sort of like balance between demineralization and remineralization. But if there are some disturbance in this, especially if there's a lot of sugar, snacks and things, there will be a fluctuation of the pH below 5.5, the critical pH, and then there will be decay. So as a dentist, we try ourselves and do help these guys in the right hand side where remineralization by either by giving fluoride, by fissure sealant, etc. So all the prevention we do. So what's the prevalence of ECC? Prevalence are different and vary from 3 to up to more than 90%. Why? Because of the different research, different methodology, different people, different children, different socioeconomic status. So as an example, I'll take the United Kingdom and the United Arab Emirates as an example of the sort of industrialized country and the third world countries. So for example, in England, if you see there's low, but again, there are what we can see in this Western country is that 80% of cases are in 20% of population. And these are namely the people, immigrant people with special needs and medically compromised patient. But in our case, if you see it's across the board. For example, in Abu Dhabi, that's quite an old study by Al-Hosni, it's 94%. And in Ajman, it's 76.1%. And in Ras Al Khaimah, it's about 74%. So it's quite high, it's more than 70%. And we conducted a study and actually a systematic review in GCC recently by Dr. Wafa Alayan, and it's actually published in the Saudi Dental Journal. And the caries in the primary dentition was, in terms of DMFT, is 5.1 DMFT. And the prevalence was about 81%, so quite high. And most of the studies actually is done in Saudi Arabia and in Emirates. This actually the study which qualified to be in the systematic review. So we did also another study in Ras Al Khaimah where the prevalence is about 74%, and the care index is only 3.8%. The care index is calculated by the number of filled teeth, filled surface over the total DMFT multiplied by 100. So usually if the care index is very low, means we have a lot of decayed and we do not do restorations. So what are the misconception or maybe the potential reasons for why we have a lot of ECC in GCC or in Emirates or in Saudi, even, as an individual country or overall? So first of all, that why we treat ECC. A lot of people actually, parent, guardian, or even unfortunately dentist. Some of them, they said, well, this is only milk teeth, why we do this? And because of this, not only if in the Arab country here or in the region, I think there are a lot of this notion. Well, that's why we have about 600 million children now with an untreated caries. Now, these people should know, that God have give us these primary teeth should stay there until their physiological exfoliation. Because if we don't do that, there will be teeth with abscesses and we have to extract them before their time. And then all the other teeth, the permanent teeth, will come stray and there will be a lot of orthodontic problems and things. There may be also comorbidity or even mortality, and especially if the if the infections go to the upper face, as you know, the upper face is actually connected with the through the veins, the emissory veins, and to the plexus, and then goes to the cavernous sinus. And this is exactly what has been done, what has been actually happened in 2007, where this Afro-Caribbean guy, 12 years old, he died because of neglect. Actually, because he went to a dentist with an abscess in upper face, and they did not give him any antibiotic, and they said, just come, you go to, I think they have no insurance or anything. There are a lot of problems in this, being he's Afro-Caribbean, and this patient unfortunately died because of the abscess, and then it's actually that's a lot of media about this. And the other thing, if the infection goes to the lower face and to the neck, it can cause lid wound gingivitis. So it's very, very dangerous sequelae of early childhood cares. Now, the second one is, some people, they have a lot of faith in GIC as a permanent restorations. Yes, GIC is very good. It bonds to dentine and enamel. It releases fluoride, and it's less technique sensitive comparing with composite. But again, it's not suitable for multi-surface lesions. The other thing is, a lot of insurance companies do not cover any sort of prevention, especially fluoride application and fissure sealant, and this is problem. People, they cannot pay, and then you cannot, as a dentist, you cannot apply fluoride and fissure sealant. Some dentists are also resistant to change, and we see this in the whole technique. And now, because maybe by time, hopefully they will be convinced. But a lot of people, they have, that thing, imminent versus, evidence-based. Some people, they are just stick to that idea or that information which they got from their teacher and their professor 20 years ago. And the last, sorry, I think I missed one slide here. Yeah. So myself, as actually, we used to do a lot of drilling and filling, and then that time it was actually the norm, where you do pulpotomy and stainless steel crowns. But nowadays people are going more of like biologically, if you like, biological treatment, and we teach our student, and we how to do this, and also we research in this, and we publish in this. Now, the other thing is the Dr. Google. وما أدراك ما Dr. Google. يعني people are actually consult Google for everything, and they come with the idea that fluoride is, for example, fluoride is harmful to the humans, and it causes cancers and causes osteoporosis and all this. So they oppose sometimes, some of them even to use fluoride toothpaste. And I'll give you, and usually, by the way, we should, as a pediatric dentist, we should, and dentists in general, we should involve parents and guardians, in treatment planning. But sometimes they have, that attitude. For example, this is one case is done by one of our ex-postgraduate, he's a specialist, Dr. Muhammad Abdu, where he explained, after doing acclimatization and introductory visit, that this child, he's a difficult child, by the way, and they cannot afford going to GA. So he told the mother that it's the best thing is to do sort of like whole crown, and maybe for that these pulpotomy and stainless steel crown, and he managed to do a whole crown. And then the mother said, we don't want these silver crowns anymore. And she disappeared for 1 year. And then she came later on with, the status that these are need to be extracted now. On the contrary, there is another lady, which has actually, this is presented by Dr. Ali Akbar last Monday. And see, if you see here, all his primary molars are actually with proximal caries, and this is a very good candidate for a whole crown. And he explained to the mother that could be done without any local analgesia, And the mother is convinced, and he did all case for all the teeth, and now he is following up this just for every 6 months and so. Now we usually jump and do sort of like and we have to do sometimes. In this case, for example, I don't blame actually Dr. Dina Mansour did very good job removing all these infections and if it's chronic sinus in the but ideally speaking, as I'm speaking as a whole, we should have the idea that we have to manage the causes of the caries before actually reach us to this point. Now, we still do a lot of GAs, and this is a quotation from here from Chris Deary. Actually, it's an editorial in the Dental Update where he actually referred it to as a national disgrace. This is in the UK, and there are, he said, I think there are 5 to 9 years old. The admission is 30% or about 31% of all GAs are due to caries, dental caries, and it costs the UK, in England only, about 30 million pound in 2012 and 13. So see, this is, and it's preventable disease. Everybody is saying it's preventable disease, but are we doing actually doing prevention, real prevention? And this is a paper which we published recently. As I said, I think we will continue doing all this because we have a lot of care. So we have to do GAs, but we have to start early with the expecting mother and the lactating mother early on, and involve, I think, pediatricians, antenatal clinics also before care starts. Because if you don't do that, we have this vicious circle of treatment and treatment. So you do a full mouth rehabilitation under local analgesia or general anesthesia, but the problem that the child, and they go to all their old habit of poor oral hygiene, poor diet, poor parenting, and they come up with the recurrent caries. So this vicious circle will repeat itself, or maybe goes to more problems, as we said, if it goes to the cellulitis phase. Now, so by doing prevention, as we always say, prevention is better than cure, we reduce cost because the average cost of full mouth rehabilitation under general anesthesia, this is actually a quite recent figures, about $8,000. And in Europe, and I think in 2020, they spent about 79 billion in oral disease cost, treatment of oral disease in general. Okay, there are also indirect benefit of prevention, like freedom from pain and discomfort, dentition free of decay, improved occlusion, psychological value of retaining teeth, and less time missed from the school. And that study, actually, there are, in the USA, there are 51 million school hours are lost due to a dental-related illness. So because of pain and infection, the children, they don't go to school. So how to prevent caries? There are individual-based interventions and community-based interventions. The individual-based is directed to either to the child or his mother, okay? And the community-based, which actually we need it in the GCC countries where we have a lot of the prevalence is too high, then you have to go to the community, to the schools, to the nurseries, and do it in large scale. And it works. And this is actually, I did my part of my PhD in Leeds, where we went to people's home, lower social class 4 and 5. They have a lot of caries in the UK. So we go every 3 months, taking the saliva sample from them, giving them, informal sort of advice. Actually, I have a dental health educator who goes every 3 months. I go every 6 months just to examine them for 3 years. And it was very, very successful. So the main dental health education, as the advice is to try to stop nighttime bottle feedings. and to substitute bottle if possible by feeder cup. We say bottle top, have a cup. After 1 year of age, the American Academy of Pediatric Dentistry that the bottle should not be used, especially at night. And healthy snacks, brush the teeth twice a day with fluoride toothpaste, and visit the dentist regularly. So I have questions for you now. So we usually give, oral hygiene instruction and dietary advice. Okay, but what do you think, which one will work better? Is it oral hygiene using fluoride toothpaste, or dietary advice by cutting the frequency and the amount of sugar? And which one that the dentist, I am as a dentist, can sort of say the compliance of the patient, of the which one is better? I mean, if you have to choose one of them, of course we have to do both of them, but which one you think it will reduce caries? See answers there. Okay, so in my opinion, it's the oral hygiene. We should concentrate more in oral hygiene using fluoride toothpaste twice a day. It has been, I mean, evidence-based. We did the studies in Leeds with the Professor Monty Dougal, an ICT, that's intraoral cariogenicity test, and a lot of studies that's been done. And as far as people, they brush their teeth twice a day with fluoride toothpaste, even if you take more than even 5 to 7 times sugary diet today, per day, there will be no demineralization, because there will be, of course, there will be demineralization, but it will remineralize. Okay, and also it's socially accepted that people are to brush their teeth, but diet is, people like sugar. Even psychologists say that it's not always it's easy to sort of say not to eat chocolate or eat sugar. So it's better to concentrate. Of course, we have to give a holistic now advice, even the WHO, that we have to reduce the frequency as well as the amount of sugar, because even for obesity and other things. But I think if we concentrate more in oral hygiene, the result will be much more better. And of course, we have to, as we said before, to stop bottle feeding, and also the sugary medicine. Also, there are free sugar medicine now available also. So there's a paradigm shift, as we said, between the conventional one, drilling and filling, to the novel or the more recent one or contemporary one is the seal to heal, like either with no or partial caries removal, like art and hole. And also sometimes we, especially in the lower anterior, we just open that lesions, and make these teeth self-cleansing. And of course, there's SDF, who was Dr. Yousef, inshallah, will tell us all about it. And so ECC management options, the paradigm shift. So if you see here, there are about 8 options, in our toolbox, and starting from Durafat, which is 5%, it is very, very good, especially, and they did study actually by Lee in 1994, I think, in Mexican children in the United States, where he called it the lip study. So what actually they did, in simply that, they went to that area where a lot of Mexican with a lot of caries, of course. So they teach the mothers how to diagnose early childhood caries, by that's white lesions. So they tell them, when you see this, they give them pictures and things, and then just bring your child to that place and we will give you free treatment. And it was very, very successful. and of course SDF, atraumatic restorative art, and the interim therapeutic restoration, ITR, open lesions and render them self-cleansing, resin infiltration, also Dr. Yousef will tell us all about it, and the whole technique. And of course, we will still do the traditional restorative options for certain children. So I have another scenario for you now. So if you have a 4 years old so with a girl with mild hemophilia and complains of slight pain in the 8-5, the pain starts with drinks and lasts for short time and then subsides without any and there is no history of nocturnal or at night pain. Clinically, there is large MO Caris lesion involving about 2/3 of the mesial marginal ridge. Radiographically, there is no pathological change. So what is the best treatment option for this? I'll give you options here. What do? You do indirect pulp capping, or you do cervical phlebotomy, or you do pulpectomy, or you do extraction for this. It's a mild hemophilic girl, and pain subsides easily without analgesics, and there is no nocturnal pain, and there is no radiographic or other clinical problems. So I think according to the last AABD recommendation is in this case, we just do bulb capping, indirect bulb capping. Before we used to do, especially if you are aware of that famous paper by Hobson in 1970s, where he said if there are 2/3 of the mesial marginal ridge is broken, then you go straight to do pulpotomy, cervical pulpotomy. And this is actually true in a way, and actually it has been proven that bacteria is usually, if there's break of 2/3 or more of the marginal bacteria is already invading the bulb. And this is actually has been published by Dr. Ayman Nouh and Monty Dougal, were in extracted teeth. And definitely there is histologically, if you see there will be a bacteria in the bulb, but the bulb can survive. I mean, especially if you do a hermetic seal, and this because as the principle of whole technique. So if you cut the bacteria from their nutrient, they will die then. So the recommendation for this is to do indirect bulb capping. Okay. We used to do pulpotomy in this, so we are more of conservative, if you like. Now, the other thing is SDF and resin infiltrate and the whole technique. Whole technique is actually introduced by Dr. Hall a long time ago, where this Dr. Hall is actually, she used to work in a sort of like an island in Scotland, and she is overwhelmed by the number of children. She's, by the way, she is general dentist. So she from her background, in biology, she actually came up with this: why I drill and fill? I just cap these teeth so there will be cut in the nutrient and these bacteria can die. And actually she did that for I don't know how many cases, and then later on, Dr. Enns came up and actually did an audit, and actually Dr. Hall, who actually did the audit, and then they found it successful, and then they did randomized clinical trials. That's in 2007, actually done by general dental practitioner, where they divided a split mouth. They did in one side a whole technique, and on the other side a conventional composite or amalgam restoration, and the results were amazing. There is no maybe 2 or 3 actually. There are failure, which is minor failure actually in the whole technique teeth, and also the other aspect of it is that it has been liked by the dentist as well as the parent and the children. So in the whole technique, these are the criteria. Actually, there is a special manual for it, and it's free of charge. You can download it, and the caries has to be in enamel or dentine D1, D2. So the most important thing is that there will be no irreversible pulpitis. So because if you cover this tooth, in the case, if there is pulpitis and there is nocturnal pain and you do a whole crown, I assure you that this patient will come with a huge cellulitis the day after. So this is very, very important, that it has to be free of pulpitis. And there will be at least 1 millimeter of dentine bridge between the caries and the pulp. And it's easy to do. You do just the orthodontic separator just to separate the teeth, and then without any local analgesia, you just put your crown and cement it with Kitaxim. Now, it's got a lot of publicity, and even the AABD, actually in 2019, they acknowledged that, and they are not really advocating, the use of whole crowns, whole techniques, but they are putting it as one of the alternative. And a lot of studies, Santa Maria studies, where they did through 3 arms RCT. One of them is the whole technique, the other is conventional stainless steel crown, and the other one is non-restorative, where what they did, just they opened the the contact area, or just to render that lesion, the self-cleansing. And of course they call this patient for that arm is every 3 months just to do Durafat, and the results are the same, especially for the whole crown. The result was very, very, very encouraging. And also Dr. Hannah Bin Laden, who is one of our postgraduate, and now she is working actually with us as a part-time faculty, and she is a specialist also in Dubai. She did her study retrospectively, where she compared, the stainless steel crown, the conventional one with the whole crown, and the result is both of them actually is working very well. And maybe in the 24th post-operatively, the whole technique was actually superior to the conventional stainless steel crowns. And we published a paper also with Dr. Manal and colleagues, where we actually this is whole technique, and also we used, sometimes it's very, very difficult to say whether it's dealing with the children. You don't know whether these are reversible or irreversible pulpitis. So what we do in that case, we ITR the lesion, just giving just temporize it with GIC for at least 4 weeks, and then if it's symptoms free, then we do a whole crown. And this is a very good paper, by the way, clinically oriented paper. So if you want to go through it, a lot of cases, also pre and post-operative photos are there. So I tried to summarize the advantage of biological approach versus the surgical approach. So as you see here, biologically, when you treat tooth, you mostly deal with the causes rather than the symptoms, and it's conservative, or either no or minimum to structural loss. If you want to do art, for example, you just excavate. If you do whole technique, there will be no drilling at all, and so accepted by most children and parents, because there is no local analgesia. It's minimal cost, and it limits the spread of infection, especially during COVID, because there is no drilling, and it promotes better future dental patient, and it's easily to taught and practice. And it's rather than doing class 2, for example, you just do that steel crown and cement. Yeah. So I have another question for you, where especially for people who have doubt now to use whole crown, for example. So if you have that a patient who is 2 years old, okay, healthy, and they come up with the when you examine them, there is an initial caries which in tooth number 7-4, and they have demineralization in the upper incisors, okay, and this girls actually have another 4 siblings, okay, and they are from middle class family, and one of the children are autistic, and they have no dental insurance. So what is the best treatment option, taking into consideration the status of the family for that tooth number 7-4? Okay, so I think we will elaborate more in this, because I think this scenario summarizes everything, or almost my presentation. So if you have this child who has got a family of 5, one of them is autistic, so the mother is really handful, and so we have to really turn the prevention for that specific. We will be sympathetic and empathetic with the mother, because if in this case you will not be dictating, brush your teeth twice a day, and so you have to really listen to her and maybe do a kind of motivational interviewing with her. Listen to her, and be sympathetic to her, and then give alternative options in prevention. Don't just be rigid, according to the book what to do. So you have to give alternative options. And the treatment, as we said, that if you remember that left lip study, for 5-1 and 6-1, we use fluoride varnish, every 3 months. And for the treatment option for that 7-4, we just go biological. Either we use, I think in this case, it's the best answer will be is the whole crown, because it will be more durable for her, because but if you do SDF or SMART or ART, maybe she will come again and things. But in this, even lab to lab, you can, I said in the scenario there is spacing there, so and it's a D. So, and we do, and my colleagues, actually, we did a lot of this just lab to lab, and we just travel that cement that whole crown for this patient. Okay, so my take-home visits is that ECC is a preventable disease, yes, but we should involve parents, we should other medical professionals, especially pediatricians and nurses, and of course the insurance companies. And there should be, I think there's a great need for a longitudinal prospective studies in the GCC countries to go to the root of the problem, why we have more caries here. Because maybe if the culture, although I worked 12 years in Al Ain, and it's a lot of cares, although everything is free, for people, and it's very, the government provide even orthodontics free, everything, but there's still a lot of cares, because maybe if the culture, they cannot say to the grandmother, don't give sweets, for example. So we have to go to the roots of the problem, and the management of ECC should be taking in consideration the biology of dental caries, treat the causes, and utilize less invasive biological treatment modalities. And these are some references. And thank you very much.
Very much, Professor Kowash, for your wonderful, informative lecture. Actually, we have a lot of thanks and appreciation in the chat for your presentation, Professor Kowash. The webinar now is open for any question. Actually, Professor Kowash, your presentation is very interesting. We actually face early childhood care as a routine, unfortunately, as a routine in our daily practice. I'm working in a tertiary center hospital. We have a long waiting list. Most of our patients is below 5 years old, most of them from a young mother and some of them from educated mother. Do you think we fail to deliver our message and education for our population as a pediatric dentist? It is our fault or whose fault?
I think it's a combination. It's us, because we concentrate more in media also. As I said, I think as a dentist, we should involve pediatricians, especially now in the United States. They can bill. Pediatrician can see, and diagnose early childhood caries, and either they refer or they put fluoride, and they can bill for it, and the insurance company will compensate them for their time. Here, the problem is actually we did even our studies. Dr. Noura did her study in her master's degree in the knowledge of pediatricians, and really it's inadequate, because even if you ask now the MBBS people and the Faculty of Medicine, they don't know about teeth. Okay, so I think there should be either their syllabus, or at least there are refreshing courses after, and they compensate them for their time, and they can bill for examination of oral cavity, and then either they treat if it's possible, and it's possible I think to apply fluoride varnish, or at least diagnose that early lesion, and then they refer and also the antenatal clinics, as you said, Doctora, you start early, pregnant ladies, tell them about dental decay, and also the prevention on how to to use breastfeeding, and then how not to give the child bottle end demands and all this. So we have to start early, and of course, we go side by side. You have decayed now, and you still do full mouth rehabilitation, either under local analgesia, sedation, or GA. But again, start with the new generations, and involve other dental professionals. Other medical professionals. Yeah.
We have a question here. What are the strategies you suggest that might help to solve the continuing problem of dental caries in GCC children?
Yeah, I think, as mentioned in my conclusion, my summary, in my take-home message, is we need really a longitudinal studies about why we have this caries. I mean, why? Of course, sugars and oral hygiene, but again, depending on nannies, for nursing and things, I think it's sometimes money. You have money, but again, it's sort of as they said, of two edges, as they said, because if you remember in that multifactorial etiology, we say socioeconomic classes. In the West, for example, lower social class 4 and 5, they have more caries. But here, if you see, it's across the board. Even people who is rich, they have a lot of caries. So we have to go to this. We have to solve these problems, and we have to, as we said before, we do longitudinal studies. We do community sort of programs, in the schools, in the nurses, and of course involving other, pediatricians and antenatal clinics from this. Yeah. And moreover, the advice we give, it shouldn't be just dictating things. You have to give a culturally sensitive messages also.
We have a question here. Can you tell us again about the study you mentioned in the hemophilic case? Question 2, please.
No, it's not a study. It's not a study. It's a recommendation or guidelines by the American Academy of Pediatric Dentistry, where the studies actually, and there is a study, I don't know by whom now, I don't remember, but they're comparing that the results, the outcomes of using the direct pulp capping and the pulpotomy in that case, where you have no nocturnal pain and the pain comes and goes without analgesic, is you just go for indirect pulp capping rather than opening the and doing surgical or pulpotomies. Yes. And of course, the hemophilic patient means that you have to strive and keep that tooth and don't extract it, being a hemophilic patient. On the contrary, if you have a patient who has have cardiac problems, then we usually go more drastic and we extract. So this is the difference between hemophilia and between the cardiac patients.
We have a question here. Do you recommend to keep a little dental plaque while cleaning child patient before teeth before the application of fluoride varnish? Or we should clean the teeth completely before application of the fluoride varnish?
That's you mean the interface between the thing? Yeah. I mean, it's the cleaning is although we do oral prophylaxis and do that, but the answer is little bit of plaque, she said.
Black, yeah. They ask about their can we keep a little black before we apply fluoride varnish?
I have no, to be
honest. You recommend to clean. They ask, I think they mean, do you recommend to clean the plaque?
Yeah,
before
we usually
applying fluoride varnish.
Yeah, we usually clean that. We do oral prophy and then we put our fluoride varnish or ABF. Yes.
The last question: would you prefer temporize the caries for 3 weeks before whole crowns?
Yes, that's in case if you are in doubt. You are not really sure that the child or the parent, they are giving you a history and there is deep caries. Still, you have that band of dentin, but again, the caries is too much and too deep. Then it's better to go and temporize it. But if you have, of course, quite substantial amount of dentin between the caries, and then just do whole crown straight away.
Thank you very much, Professor Kowash. And on behalf of Saudi Society of Pediatric Dentistry, we would like to present you with a certificate of appreciation. It was a pleasure to meet you, and hopefully you will join us again in new activity. Thank you very much, Professor.
Thank you very much indeed. Thank you. Thank you.
Present to you the certificate of appreciation.
Thank you.
Our next presenter, Dr. Yousef. It is a privilege to have him with us today with his lecture about minimally invasive restorative technique in pediatric dentistry, SDF and resin infiltration. Dr. Yousef obtained his bachelor degree with honor from King Saud University 2002, and he had a certificate in pediatric dentistry and master in public health from University of Iowa in 2008. And in 2011, he received his PhD degree in oral science, and he is certified with American Board of Pediatric Dentistry in 2012. Currently, Dr. Yousef is an assistant professor and consultant at Preventive Dentistry Department, Imam Abdurrahman bin Faisal University. Welcome, Dr. Yousef, and you can share your screen and start your presentation.
Thank you very much, Doctor. Assalamu alaikum wa rahmatullah to everyone, and good evening. Is my screen showing now, or?
Yes, it's clear.
Okay, perfect. First of all, I'd just like to thank the organizers for their gracious invitation and astute preparation. I also like to thank the audience for their attendance and hopefully attention. What I'm hoping to do today, let's see if we can get this to work here, is just briefly touch on a couple of minimally invasive techniques that I wouldn't say are new per se, but have been garnering more attention in the recent past. One of the reasons, of course, is because dentistry as a whole, as Professor Mawlood has mentioned, is moving more towards prevention and minimally invasive techniques as and when, of course, are appropriate clinically. So I'm just going to give, we'll start off with silver diamond fluoride, and I'm just going to give a quick synopsis on SDF, which more so than any other new techniques has been becoming more and more popular, it seems. Over the past few months, personally, I've had several patients come in asking specifically about SDF, about its safety, and about using it as an alternative to, for instance, going for general anesthesia or things of that nature. So obviously, like with other materials and techniques we use, it's important to have a good understanding of where it initiated and how and when to use it in order to gain the maximum benefit from its use. So with SDF, initially silver as a preventive material was suggested back in 1920. But over the past 40 or 50 years, SDF, as we know now, has been used in Japan, not only to prevent caries, but also to prevent its progression, try and arrest it, as well as with hypersensitivity in permanent primary teeth. Over the past few decades, it has started to get some popularity around the world. In places such as China and Australia, they've been using it. And then recently, it was approved in the US for use, initially as a desensitizing agent, and then now more as an interim caries agent. And thankfully, in the past 2 years, it has also gained approval here in Saudi Arabia. The 38% SDF is the composition usually used and most commonly used, and you can see a breakdown of its composition. If you note the fluoride content of almost 45,000 ppms, which is almost double of what we gain from use of fluoride varnish, and almost 4 times what we get from APF. So already you can see that there's a powerful punch when it comes to the fluoride benefits from SDF, and we'll talk a little bit about why we think that is. SDF, of course, as a material is colorless and it's also alkaline, so that also helps towards the caries prevention aspect. Although we do know that the fluoride content is pretty powerful within the SDF, the exact mechanism of how it is doing these different effects that we believe that are coming from the SDF is not completely understood. There have been several theories given out over several different studies. And I'll try and give a little bit of summation. If we look at the fluoride content, obviously the fluoride is going to work on the mineral portion of the tooth, as we all know. It seems to prepare or to gas calcium fluoride, which acts as a reservoir for fluoride. And that, of course, has the usual effects that we have a good understanding of, similar to what Professor Mawlood talked about the remineralization and demineralization balance around enamel, as well as its benefits with regards to already affected dentine. It helps in creation of fluoroapatite, which of course you know is more resistant to caries formation, as well as hardening the tooth surface itself. It's also thought to help with decreasing the permeability of the enamel. The silver, on the other hand, is thought to work more so on the protein aspect of the tooth structure. So we get silver protein, which has antibacterial benefits, as well as also helping with decreasing the permeability. It's also thought that silver has an effect on the mineral portion as well by creating silver phosphate, which adds, of course, to the hardness of the tooth surface, in addition to the antibacterial properties that we believe or is believed to help with the effectiveness of SDF as a preventive material. Multiple studies have been done trying to look at these different effects of SDF on tooth surface. If you look at the photo on the top, you can see how SDF clearly decreases the permeability, increases hardness. of a tooth surface, as well as the dentine surface underneath. It also has an effect on the agglutination of Streptococcus mutans, which helps decrease their activity level. Also, of course, which would help theoretically in decreasing the progression of caries. Now, although the process is not fully understood, there have been multiple studies that have looked at the efficacy and the effectiveness of SDF on caries and on caries progression and hypersensitivity. Back in 2016, a meta-analysis was done that showed effects ranging to around 81% overall caries arrest in that first year. By the second year, it's a little bit down to around 65%. Similar meta-analysis done where they looked at randomized and controlled clinical trials. They also noted around 68 to 70% caries arrest in primary teeth over those first 2 years, whether the SDF was used once or twice, and we'll talk a little bit about that in a bit. But in both cases, the effect was seen. Also comparatively, in a recent study, they found that SDF compared to usual modalities that we use, such as fluoride varnish and GIC, had higher caries arrest rates, and thus more effective, hopefully, in the stopping the progression of caries. Overall, the APD panel that was compliant supports the use of the SDF as part of the comprehensive caries management program or management techniques that you are going to apply for the patient. Their support, of course, was conditional from what they deemed as low quality of the overall evidence provided. Although there have been a lot of studies, the level of quality has not been at a level where they can fully recommend it. As I'm sure a lot of our listeners know, conditional recommendation basically means that it does have benefits, but it will not benefit all patients in all cases. And so they're putting it back in the hands of the physician, of the practitioner, to use their clinical judgment and expertise in deciding if SDF is a good modality for that specific case. But although they have put this sort of conditional recommendation, they have provided in addition to other or institutional panels have provided some selection criteria. So when it comes to the tooth itself, similar to the techniques that Professor Mawlood talked about, you want to make sure that there are no signs or symptoms of pulpal infection, pulpal exposure, or inflammation, signs and symptoms that we're all familiar with. In other words, carious lesions that are not encroaching on the pulp. There have been some case reports on some minor exceptions to this rule. For instance, if you have an asymptomatic tooth that's deemed non-restorable, but you don't really want to extract it, for whatever prognostic or diagnostic reasons that you have, SDF has been used in those situations. Also, teeth that are symptomatic, but more because of hypersensitivity, because of developmental issues or things of that nature. SDF has also been shown to be effective in those situations. The other criteria is that the surface to be applied to is accessible. And again, I put an asterisk there because there are some case reports, some studies that have talked about using it in inaccessible areas and some techniques which we'll talk about later when we talk about the application itself. But mainly those two criteria. You want a tooth that's not showing any symptoms and signs of pulpal infection, pulpal inclusion, and at the same time, you need to be able to access, obviously, the surface in order to apply the SDF. If we look at the different benefits of SDF, the fact that it's inexpensive and relatively easy and quick to apply, there's minimal invasiveness, so less working time needed, and also, like we talked about, the fluoride delivery, almost 2 to 3 times that of what we see within varnish or with GIC and things of that nature. The main disadvantage, of course, is the staining potential, which I'll talk about in a minute or two. But if we look at those advantages and we think about the criteria that we usually use on a daily basis in order to treatment plan for our patients, this goes towards the conditional recommendation that the APD have put out. So if I take those advantages into consideration, disadvantages, and I couple that with the criteria that we usually use, it's easy to discern which patients might be or might benefit most in these cases the use of SDF. For example, if you have a young pre-cooperative child where your working time is limited, you might think about using this as opposed to the ART technique, which has a lot of drawbacks in and of itself. Also, if you had a patient where there are multiple carious lesions, maybe GA is not an option because of financial reasons or because of the preference of the family or medical reasons. SDF might be a good alternative. You could have an older patient, maybe slightly apprehensive or maybe cooperative, but because of the number of carious teeth, you want to control the carious environment, which control the oral cavity health status in order to progress slowly as part of your long-term plan. So all situations, all conditions that we can sort of discern, taking into consideration the different advantages of the use of SDF. The main disadvantage, of course, is the black staining, the potential to stain. Very important if you do decide to use SDF is to make it clear to the parents that the carious lesions is not to be removed. The placement of the SDF is going to leave it more discolored, more blackened than what it is, with the idea, of course, of using the benefits as opposed to restorative or more definitive treatments because of all the factors that we talked about. Also important that they understand that there could be staining of some of the soft tissue, the gingiva or the skin, and we'll talk a little bit with application about how to avoid that or to minimize that. But when it comes to that staining, it's usually temporary with the rollover of the surface skin or gingival cells. You lose that staining within 1 to 3 weeks. Also, there's potential of staining of clothing and other materials around your working area. So as long as they understand that and they consent to that, then I guess you're free to go. You're free to go to start up with it. When it comes to the application of SDF, like we said, because of this staining potential, you want to make sure to apply protective coating to the lips and skin. Just as a side note, there are multiple videos online that you can view that will take you through this step by step, whether from the manufacturers or from dentists that are applying it. But just to touch up on some of the points that I'd like to cover here. So once you apply the protective coating to the lips and skin, you want to make sure that you're isolating the teeth that we're going to be applying the SDF to. With cotton rolls or other isolation techniques. You want to make sure that you're removing most of the gross debris. That'll help, of course, with the SDF contacting the affected dentine. Not necessarily, of course, to remove any of the carious lesion itself, which is the idea behind this. And then you want to make sure that you're air drying it very well. With the application, you want to make sure that you're applying it carefully, like we said, avoiding the gingival, avoiding the soft tissue. You only want to apply it to the affected areas. As mentioned before, one of the criteria being that it's an accessible area. There have been some case reports that talked about placing it in interproximal areas using spongy floss. The only issues to think about, of course, is if you are using that, it does decrease your ability to control the amount of SDF that you're applying. Also decreases your ability to control any staining potential that might be around the gingiva or in other places as well. So just as a side note there. The AAPD recommends using 1 drop as a whole per appointment in order to decrease any systemic absorption. You also want to remove excess liquid before applying it to the teeth. There has been studies, if I remember correctly, in the UK where they tried to calculate the amount of SDF that would be safe, that safely could be used, and they calculated at around 1 drop per 10 kilograms. So of course, the older the patient, you can use more, but if you're going according to the American Academy of Pediatric Dentistry guidelines, you want to only use 1 drop per appointment, and that should suffice, should be enough to cover 4 to 5 teeth application. The application itself should be over a minute at least. And then you can see with time, you can see the sort of darkening of the teeth. as it starts to take effect. You want to, of course, want to remove the excess if possible, again, to minimize any systemic absorption. And then the most difficult part, I guess, of applying the SDF is it's recommended to have at least 2 to 3 minutes of isolation, maybe air drying. Some people have, or some studies have advocated using light cure as well, just to hasten its hardening and then, of course, decrease the potential for any staining of the soft tissues. The APD also recommends applying varnish, fluoride varnish, to any untreated teeth, just to complete the circle of prevention. When it comes to follow-up, the recommendation is to give it 2 to 4 weeks and then follow it up. And then as part of your long-term plan, either applying more SDF during follow-up appointments. Studies have shown biannual application to be more effective than one-time application. There aren't really any studies that have looked at more than 2 or 3 applications and compare them to just biannual applications. So that's the recommendation they're going by. Also, studies have shown that applying it on anterior teeth have been higher arrest rates compared to posterior. A number of possible reasons, but just as a general overview of its benefits. If the idea long term is to use this as your sort of final step, waiting until the child maybe is older, or as a interim step before finalizing restorations, you have to take that into consideration, make sure that the parents are also on board, have them follow up to make sure that there's no recurrent decay, that the SDF is doing what we hope that it's doing. Now, if the idea is to have it as part of a interim step before a final restoration, for instance, applying a strip crown on those teeth, it's recommended to use an opaquer in order to disguise the discoloration that you have, because discoloration is fairly strong, especially as time goes by. That is one option. Another option, like Professor Mawlood talked about, is using the Hull technique. Personally, I've been using the Hull technique in accordance to what was recommended maybe for the past 10 or 15 years. As Professor Mawlood mentioned, very effective technique. However, with the Hull technique, since we are using it a lot of times with younger patients, it's very difficult to get radiographs. So you're basing it more on your clinical judgment, more on the subjective symptoms that are given by the parents of the child. And so in a lot of cases, we're depending on the crown itself because it's covering the whole of the tooth to stop the caries progression. And we're using GIC cementation to give us a little bit of added benefit. With the SDF now available, that could be a great interim step to where you're placing the SDF, controlling the caries. There's no signs and symptoms in 2 to 4 weeks or so, or even if you want to do it directly, and you can place your crown with no to minimal tooth preparation needed, especially for those younger patients or for those special healthcare needs patients where GA maybe is not a real option. These are a couple of slides. These are courtesy of Dr. Miri Ibrahim, who's one of our colleagues at the university. She's actually conducting a test looking also at SDF clinically, comparatively to other medicaments, other modalities. Hopefully, once her and her team are done, they can add to the literature that we do have. And you can see after the initial application, slight darkening, and then that sort of increases a little bit with time. And then, of course, in a case like this, you might think about later on doing a strip crown or simple class 3s if that's an option. But like I said, using a opaquer is probably your best option in order to avoid having any staining underneath showing through. Similarly, in the posterior teeth, fits and fissures. Important to note that you do make a note of this in your progress notes. Also important that the parents have this well understood, because you don't want another dentist looking at this and maybe misinterpreting this as arrested caries that needs treatment and not as an interim step for as part of a long-term plan that you've initiated. So I'll move on to the next technique that I was hoping to talk about, which is resin infiltration technique. Again, another technique that has sort of been gaining popularity over the past few years. Briefly, it is the use of a light curing resin with the idea that this would penetrate into the porous lesion body of the caries. The material used is very low viscosity, so that helps with the penetration. And then theoretically, once you have the penetration there, this will create a barrier, which will hopefully prevent progression of the caries lesion. With regards to the mechanism of action, again, it's really dependent on the infiltration step there, where if you remove the outer layer, usually with an acid, which is less porous, and that will remove the barrier that's probably not allowing your resin infiltrate to properly infiltrate into the porosities. Once you remove that outer barrier, the infiltrate itself, because of its low viscosity, because of it being unfilled, will go through, will be able to close up those porosities. It has been shown that the refractory index of this resin is very similar to that of enamel, and that's how it sort of masks the different lesions that we're trying to affect with its use. Again, although there have been many studies that have looked at this, the amount of evidence is not considered high quality, similar to the SDF. However, the different institutional organizations have put up or put forth certain selection criteria. When it comes to resin infiltration, the most important criteria with regards to tooth selection is that it's not cavitated. The enamel lesion, similar to what Professor Mawlood was talking about and with those Hull techniques, is at most you want it at D1 depth. Radiographs, of course, will be a great benefit when it comes to trying to discern the depth, but in cases where we can't get radiographs done, especially with the very young children, or the radiographs aren't diagnostic quality, so you're basing more on your judgment. In a lot of situations, we're looking more towards not only the symptoms, but also maybe using this as an interim step, and then with the follow-up, you can have a better understanding if the lesion is truly within that D1 depth, or maybe beyond if some certain symptoms start to show up, and then you'll have to move on, of course, to a different modality, something more restorative, more decisive. It's also been used with non-capitated lesions that have certain developmental defects, whether from fluorosis or white spot lesions, or sometimes hypocalcification. As I mentioned, the APD as well as the AAD both support its use in non-cavitated caries lesions, but again, the recommendation is conditional because of what they deem as low quality evidence overall. Hopefully in the future, with more definitive clinical trials, we'll be able to have a better understanding of how it does work and how effective these techniques are. And although the long-term effectiveness of resin hasn't clearly been shown, some studies show that it can last up to 2 years. Some studies show up to even 6 years. And in any case, it's still looked at more as a long-term treatment option because of the fact that it's minimally invasive. Also, the fact that it's not time-consuming, so having to touch up on it later on won't be too much of a hassle for the patient or for the dentist. If we look at the application technique of the resin infiltration, again, similar to the SDF, you want to isolate properly. You're going to apply an acid gel. What's recommended is 15% hydrochloric acid, and you can apply this up to 2 to 3 times for 1.5 minutes to 2 minutes each. What you're trying to do, of course, is not only acid etch the external surface to remove that less porous enamel surface, but also you're trying to decrease the amount of staining that's already showing there previously because of the developmental issue or white spot lesions or things of that nature. We want to make sure, of course, we're covering the whole of the tooth structure in order to get more of a uniform application later on once the resin is applied. We're going to remove the excess of the acid. You want to rinse and dry, similar to what to the technique you use when you're doing regular acid etching, so maybe a few minutes. And then very importantly, you want to dry the lesion. Using air dry, or in some cases, ethanol if it's provided by the manufacturer. Again, you want to make sure that the application is covering the whole of the tooth in order to make sure it's fairly dry before applying your final resin infiltrate. This ethanol also provides a little bit of a protective coating as well. So it's very important to make sure it's covering the whole of the tooth. And then of course you're going to apply your resin infiltrate. Like I mentioned, this is very viscous, very watery. So small amounts, applying it to the whole of the tooth. Similar to the SDF, you want to make sure you're giving it at least up to 3 minutes in order to get good penetration. You want to make sure that you're removing the excess with cotton rolls, as well as interproximally with your floss, which of course is going to decrease or help decrease the amount of finishing time that you need. And then of course you're going to light cure for 40 seconds on all sides. Once you're done with that, you're probably going to want to inspect again. And then if needed, you can apply more material. For additional applications, 1 minute application is sufficient. And then your final polish will give you hopefully the view that you want with regards to the final result. Again, in those top pictures, this is post-orthodontic treatment. You can see the white lesions showing around where the brackets were, and then this is after application. Especially on those laterals, marked differences can be seen. On those lower photos, lesion or staining lesions because of developmental issues. Again, fairly satisfactory result with regards to its application. If need be, of course, you can apply it again or follow up later on if required in 2 to 4 years. So like I mentioned, I tried to give just a brief synopsis on both techniques. Hopefully you find it of benefit. Both techniques are garnering a lot of attention as of recent, as good alternatives to what we deem as more usual surgical interventions. And hopefully with these two techniques within your arsenal, you'll be able to have a broader choice of treatment options when it comes to different types of patients that you're seeing in your clinics. Thank you.
Thank you so much, Dr. Yousef, for this informative presentation. Thank you for explaining in detail the technique and how to apply, especially SDF, as it's recently get approved by here in Saudi Arabia. A lot of pediatric dentists, they don't have a lot of experience because it's a new trend here in Saudi Arabia. So thank you very much. We have some questions. Somebody asked, do you mention the staining potential of SDF regarding caries lesion? Are there any words regarding the possibility of staining is existing tooth colored restoration as well?
Oh, yes, thank you. Yes, to answer your question briefly, yes, there is the potential of staining any restorations, tooth colored restorations on adjacent teeth. So again, when it comes to isolation and application, you want to make sure that you're very careful when applying it. You want to make sure that you're isolating other teeth. Of course, the good thing with the tooth colored restorations, if they are stained inadvertently, you can always polish by removing that outer surface and reapplication if need be. The other issue, of course, to keep in mind is if you are applying it adjacent to a permanent tooth where there might be a white spot lesion, these white spot lesions can also be stained permanently. And of course, fixing those lesions would be actual restorative techniques. So you want to make sure that when you're applying the SDF itself, that you're very careful, applying it only to the affected areas. Additionally, you want to place some sort of protection on those other teeth, whether it's by using a matrix or in some situations even placing some Vaseline or bonding agent on the other teeth to avoid direct staining of those teeth.
Great. Also, we have here questions. A lot of parents, they ask about the toxicity of silver. There's any percentage that the soft tissue could absorb the silver and it may harm the patient systematically?
Yes, that's a very good question. When you look at even the AAPD policies and guidelines, they do talk about trying to minimize the systemic absorption, mainly because of course, the silver content. And of course, we minimize that, like we said, by only placing 1 drop per session, removing excess before application and after application. The main issues I think with the silver that have been shown is if there are any allergies, contact allergies. Of course, the metal that usually comes to mind is copper, but silver has shown to have, for some people, to cause allergies. So you want to make sure you ask about that beforehand. However, with regards to toxicity, because of the minimal amount placed, there's very low possibility of toxicity issues.
Mm-hmm.
But it's a good thing to talk about with the parents beforehand.
Yeah. Okay. Somebody asked about what's the rate of application of resin infiltration? Is it biannually or?
Well, again, for the resin infiltration, it really depends on your result that you're looking for. If you're able to get that initial result that looks fairly acceptable for you and for the patients, then there's no real reason to come back to it. Like I said, the studies have shown that it usually will last up to 2 years. So although it's not long-term, it is considered a long-term treatment in and of itself. Some studies have showed the results to last up to 6 years, but nothing really definitive with regards to the amount of time. So what we usually tell the patients is, we're placing this, it's relatively long-term. However, if staining occurs, if you feel that you would like to reapply it, or similar to bleaching, if you feel that the results are sort of fading away, then you can stop by and we can reapply again. But it really all depends on the patient's preference and on the results that you want to achieve. But nothing definitive with regards to the studies as far as how many times it should be applied.
Someone asked about if there is any tools to help application of resin infiltration in interproximal area.
Oh yes, that's a very good question. Actually, when it comes to the interproximal areas, if you review the literature, again, there, like I said, there are a lot of videos online that show the application, also interproximal application. What's advocated is that of course, you need to be able to access that area. Now, if there's spacing there, fine. If not, you can always use orthodontic separators to get some.
Dr. Yousef? Are you still with us, Dr. Yousef? I think there is disconnection. Can you repeat the answer, please, Dr. Yousef?
As I was mentioning, there are videos online that talk about interproximal use, whether you can place an orthodontic separator to gain some spacing, but there are also interproximal, what they call applicators, similar to a matrix, sort of like a celluloid matrix that can be fixated to the application syringe. And then, so once you have the separation there after the orthodontic separators have been placed, they come back, you remove the separator, you can, after you go through the motions of the acid etch and so on, once you're ready to apply the infiltrate itself, the matrix will allow you to press that material into the interproximal areas. And then of course, before you light cure, again, you want to use the floss to remove any excess material over the surface. But very similar to the technique that we talked about before. The manufacturer that does provide the resin infiltrate inside, or even does also have that interproximal matrix that can be applied to the applicator itself.
Somebody asked about SDF. If the aesthetic is required, is possible to apply SDF and covered with glass ionomer in primary teeth?
Yes.
Cover the
Yes, like we said, the SDF, of course, can be in and of itself your interim or to an extent your final procedure. But if the idea is to do what they call the SMART technique, which is after SDF, apply a final restoration, you can go for, glass ionomer, you can go for comprimer, you can go for the Hall technique, which is applying the stainless steel crown or strip crown anteriorly. The only suggestion that they do talk about is using an opaquer beforehand, because you don't want to remove your SDF per se, but you do want to mask the discoloration, and the discoloration is fairly strong. So in order to do that, applying an opaquer and then applying maybe glass ionomer on top. If it's just glass ionomer on its own, not a crown, for instance, of course you're going to add in your retentive features. For instance, a class 3 or in those large class 5s, you want to make sure you have undercuts around the proximal areas in order to hold your glass ionomer, or applying a dovetail, all techniques that we're familiar with. But with regards to the surface that has been covered with SDF, it's recommended to apply the opaquer in order to really mask that discoloration as best possible.
The last question, Dr. Yousef, if we take the patient to treat it under GA, do you prefer to use SDF or use conventional restorative treatment?
Yeah, no, I mean, I guess this goes back to your personal training. From my point of view, the way that we were taught, when you go to GA, everything needs to be definitive. SDF is a great material. We've been using it for a while, even here at the college, has given very good results. But again, it's just one tool out of the many tools that we have. If you're going under general anesthesia, you're trying to finish all the treatment together, you want to make sure everything is definitive, similar to, say, the Hall technique or the art technique. Great techniques to use. However, if under GA, or if possible, to use something more definitive where you remove all the caries, you make sure, and whether or not the pulp is involved, and then you finalize the restoration. In those situations, I would suggest finalizing the treatment as a whole. However, if you do have a situation where the caries is deep to where it's close to the pulp, but there's no real exposure, then applying SDF underneath your restoration could give you benefits similar to what we've been doing for multiple years, which is applying, bases or calcium hydroxide or glass ionomer underneath our final restorations in order to get the benefit of fluoride. SDF has been shown to give 2 to 3 times the benefit of what we're getting with other modalities. So surely it is a good material to have within your arsenal.
Okay, still we have one more question. Do you think that covering SDF with a layer of petroleum jelly, Vaseline, or fluoride varnish will minimize the systemic absorption of silver? And do you think Vaseline is better to avoid fluoride toxicity?
I think it's a good idea. I haven't per se seen any studies that have looked at that as a modality. I think the fact that we're minimizing the use or the amount of SDF per appointment to just 1 drop, in addition to removing an excess before and after application, should keep it as minimal as possible. Applying an additional layer of protectiveness overneath, as long as the SDF has already dried. So we're using the air application afterwards to make sure it's dry before allowing the patient to leave. Like we said, we do that for about 3 minutes. That in itself should minimize the amount of systemic absorption. Placing petroleum jelly or in the other case, a bonding agent might also help, but again, you have to remember these are temporary covers, so with time they're going to resorb off. So if there is any excess of silver or fluoride, it might get into the system. But overall, if we're taking those initial precautions into consideration, I think we are on the safe side, hopefully. And like I mentioned, there is a study, I believe it's in the UK, where they calculated the amount of, when it comes to SDF, the safe amount to use per kilogram. And what they advocated was one drop at most for every 10 kilograms. And in most cases, the case that we're using these patients for, we're not going to go beyond 1, maybe 2 drops if it's an older child and you're trying to do multiple teeth. So hopefully, all in all, taking those precautions into consideration, it will deem it as a safe procedure to go ahead with.
No more question, Dr. Yousef.
Okay.
Thank you very much for your presentation. And on behalf of Saudi Society of Pediatric Dentistry, thank you for being with us today. And we would like to present you with the certificate of appreciation. Thank you and pleasure to meet you, Dr. Yousef.
Thank you very much. Likewise. Thank you very much again for your hospitality, invitation, and great preparation and presentation, all the work that you guys do to benefit pediatric dentists and general dentists, surely within the kingdom and hopefully within the general region as well. Thank you.
Thank you. Thank you, Dr. Yousef. Finally, I would like to thank all those who joined the webinar this evening and looking to see you in the next activity. I extend my appreciation to Saudi Society of Pediatric Dentistry. Thank you very much. We reach the end of our session and wish you a pleasant night and goodbye. Thank you.